Our next speaker is Dr. Jason McDougall, a professor of pharmacology and anesthesia at Dalhousie University. He holds a PhD in joint physiology from the University of Glasgow and is internationally recognized for his work on arthritis, pain, and inflammation. Dr. McDougall investigates how cannabinoids, sodium channels, and terpenes may help manage chronic joint pain and inflammation. According to the Canadian survey, between 20 to 30% of medical cannabis patients report using it to manage symptoms of arthritis, underscoring the pressing need for continued research in this field. Dr. McDougall's work is both timely and critical. Please welcome Dr. McDougall.
Okay, thank you very much, Carolina, for the invitation, and Avikana as well. Very happy to be here and share some of our work that we've been doing for the last 15 years to try and understand the role of cannabis and cannabinoids in the management of arthritis, pain, and inflammation. So, unfortunately, most of us, the majority of us, will live with some form of musculoskeletal disease. Roughly about 65% of people over the age of 70 will have some form of musculoskeletal disease, and mainly affecting these joints, not necessarily those joints. And the main symptom that, of course, that patients are reporting is the chronic pain. And I remember when I first started working in this area that a lot of individuals kind of poo-pooed the idea of using cannabis to try and treat their arthritis. And it was difficult to get funding to do a lot of this work. But, you know, we persevered. We heard anecdotally from patients, you know, that it seemed to be effective for the treating and managing their disease. And so, you know, we believed in that and found some good basic science, or fundamental science, to make this a little more acceptable and palatable by the community at large. So it's actually, I got the number, Carolina, that 65% of people who are using medical cannabis are actually using it for their arthritis. It improves sleep. It's been shown to improve patients' sleep, improves their mood, obviously helps alleviation of pain, and getting people moving and active again with cannabis use. Of course, the euphoric side effects really limited our willingness to use cannabis. So we've been looking at different non-psychoactive components within cannabis, as well as, you know, the trying to maybe peripherally restrict the cannabis compounds to the area that is painful, and in this case it'll be the joint. So on that last point, we did some work where we were the first to show that actually cannabis receptors, the CB1 and CB2 receptors, are not just located in your brain, but they're out in the periphery. And we were the first to show that these receptors to which the cannabis compounds bind to are present within our joints, our knee joint in this instance. So what I'm showing here is this is from the synovium, which is a very thin membrane that covers the inside of the joint that has tons and tons of pain-sensing nerves in it. And we were able to localize, and that's what the arrows are pointing to in the diagrams. They're areas that are staining positively for the CB1 and CB2 receptors. So they are present within peripheral tissues, including our joints. So what could we do to try and target these receptors locally within the joints to modulate the pain, thereby circumventing any higher order effects within the brain, so avoiding some of the euphoric potential side effects. So this is how we go about doing it. We have very complicated little experiments that we do in rats. These are single unit in vivo recordings from the pain sensing nerves. So the animal is deeply anesthetized, so it's not feeling any pain, of course, but what we're interested in are those electrical activity that's occurring within the joint itself that really initiates that pain. So we fix the femur so you don't get any hip movement. We fix the ankle so you don't get any ankle movements, and now we can do rotational movements to the knee joint and measure how much force we're applying there. And then very, very carefully we tease out individual neurons, put them on a recording electrode, and see if we've got a joint pain sensing nerve, and then we can record the electrical activity from that nerve, and that increased activity and electrical activity from that nerve would be interpreted by the brain as pain. So what this is really showing and allowing us to do is to have an objective measure of, in inverted commas, pain. And then we can apply our drugs of interest locally to the joint to see what effects it has on neuronal activity. Okay, so here are just some example recordings. Pity I don't have a pointer, but I'll kind of try and orient you through what's going on here. So on the top, this is the electrical activity that's occurring within the joint when we do two different types of movement, so movement in the normal working range and then something that's like a hyperrotation of the joint, which would be considered a painful stimulus if the animal was alert. And you can see that when you do that noxious type of movement, oh, thank you so much, that's great. So when we do this noxious type of movement, that you can see that the activity of that nerve is dramatically increased, and that would be interpreted by the brain as pain. Now when we came along and did the same sort of movements, but this time we gave CB1 selective agonist, so just activating those CB1 receptors, and you can see that the firing frequency of those nerves is dramatically decreased. That means we've been able to reduce the pain activity locally within the joint, and therefore it doesn't get into the brain, and we don't feel the pain. We then repeated with a CB2 agonist, and this is where things got a little bit murky. So this time we gave this CB2 agonist with this long, complicated name for a GW compound. And to our surprise and disappointment, it actually increased the activity of the sensory nerves, so indicating that this was being pronociceptive or pain-causing type of compound. Now, we haven't pursued other CB2 agonists. That's not to dispel that other CB2 agonists could reduce mechanosensitivity, but just in this particular study, we actually found it had a confounding effect. Stuck. There we go. Okay, so what about some of the non-euphoric phytocannabinoids? And so this, we looked at cannabidiol. Now we, anecdotally at least, know that cannabidiol is effective for reducing pain, but we wanted to put some science behind this to really confirm it. So once again, doing our electrophysiological recordings, this is before giving cannabidiol, again, locally to the joint. This is a very localized application. And post, you can see that the firing frequency is again dramatically decreased. So we're reducing that pain information from getting from the joint in the first place. So just to summarize that. Okay, so that's all well and good, doing some of the electrophysiology. It's very powerful, difficult experiments, but they're very powerful information that we can get from it. But of course, what about actual pain itself? So the two techniques that we use to assess pain in our rats are something called von Freiherr algesiometry and simple weight bearing. So in this first instance, what happens is that a filament of certain bending force is just applied to the hind paw, and the bending force can get stronger and stronger and stronger. And when the animal feels that, it'll move its paw away and lick it and everything, and that's indicative of some sort of allodynic effect, so a pain, kind of a increased tactile sensitivity. And then in the second instance, this is the animals allowed to walk around this little box, and the floor of the box is supplied with a pressure sensing pad, so you can measure how much weight it's putting on one leg versus the other. Okay, all that to say, so anything that's going in this direction would be indicative of more pain in this animal model of osteoarthritis in this instance. So on the left here is our von Freiherr geometry with the withdrawal threshold. You can see that normally it takes about 15 grams of force before an animal will move its paw away. When we give osteoarthritis, obviously it takes a lot less force before it'll sense that. And so the purple squares here are just our vehicle control, and then CBD as in a dose of 300 micrograms. We don't all give massive doses to our animals, so this one's 300 micrograms. You see that you get this nice time-dependent reduction in pain. And that's also borne out in the weight distribution experiments as well, that an animal will now suddenly start putting more weight on its osteoarthritic leg because it's feeling less pain. What about inflammation? So we also look at whether cannabinoids can affect inflammation. And so in these experiments, we do something called intravital microscopy. What occurs is that a dye called rhodamine 6G is injected into the animal, and what this dye does is it labels all the white blood cells within the circulating system. We can then expose the knee joint and look at how these white blood cells interact during an inflammatory reaction using this specialized microscope. Now, leukocytes, or the white blood cells, when they're flowing through a tissue, and the tissue's inflamed, they do two very interesting phenomena. The first one is that they do this rolling. So hopefully the video will work when we show it next. I'll show you what this looks like. The white blood cells do this sort of rolling effect, and then they stick to the inside of the blood vessel. And then after they've stuck to the inside of the blood vessel, they then move out of the blood vessel into the tissue, and that's where they release all their little goodies, to produce the inflammation and also maybe sensitize the nerve and pain. So this is a nice way of trying to assess inflammation in this model of arthritis. Okay, fingers crossed. Let's hope we can. Could you run the video, please? Here we go. Great. So this is the vehicle control. So here's a blood vessel. All these little white dots are the leukocytes, and you can see them slowly flowing through. Some of them are stuck to the side and doing that rolling. Now, after we've treated with cannabidiol, you see that maybe you get the odd one that does the rolling, or maybe one up here. But in general, those white blood cells are flowing through those blood vessels, indicating that this is having an anti-inflammatory effect in response to the CBD. And we can just plot this. So anything going in this direction now is like more inflammation. This is our rolling leukocytes, and we count the number of adherent leukocytes. As I say we, it's the royal we. I get, the students do that very kindly, to spend a lot of time doing it. So here's our vehicle control in the purple, and you can see that with both rolling as well as the adherent leukocytes, it's dramatically reduced over this time course by locally applying the CBD just to the joint. So it's having its anti-inflammatory effect. What about the nervous system itself? So in a lot of arthritis patients, or a proportion of arthritis patients, their nerves actually become damaged themselves, and this gives rise to something called neuropathic pain. It's a stabbing sort of electric shock type of pain that some osteoarthritis and rheumatoid arthritis patients live with. So we wanted to see, could we repair those nerves, those damaged nerves in our models of osteoarthritis? So what I'm showing here are electron micrographs, so looking at the actual nerve fibers themselves, taken from an arthritic knee joint. And what these arrows are pointing to on the left panel here are nerves that are either damaged or they've lost their coating, they've lost that myelin sheath, and so now they're going to be firing at an erratic sort of way and producing this neuropathic pain. When we treated the animals with CBD, you can maybe clearly see a lot of these nerves now they're thicker, they look healthier, they've got their jackets back on, they've got their coats back on, and these will hopefully reduce that level of neuropathic pain. And we can just plot this by something called a G ratio, which just looks at the thickness of those nerves. And CBD is improving the nerve integrity. So, reducing pain, reducing inflammation, protecting nerves against damage. So in this part of what I've shown is that we have an endocannabinoid system, so the receptors are there. We've also done experiments looking at the endogenous cannabinoids being produced in the joint. CB1 reduces pain. CB2, I think the jury's still maybe a little bit out there. We found using our compound that it actually increased pain, but I know others have reported CB2 agonists reducing pain. And as I said, CBD analgesic, anti-inflammatory, and neuroprotective. Now, what about some of the other compounds? So, as we know, cannabis is an extremely complicated plant. There are over 120 different types of cannabinoids. There's probably about 300 different flavonoids and terpenoids and all other sorts of goodies. They're very, very complicated. And so we became interested in looking at one of the terpenes, beta-myrcene. And the reason we picked this is that just talking to arthritis patients, they seem to like the strains that had a sort of turpentine balsamic aroma to them. So this was just anecdotally, just chatting with them, and when we looked into it, it's that sort of balsamic terpy sort of smell is produced by beta-myrcene. Beta-myrcene is found in hops, it's in mangoes, it's in many different plants, including bay leaves, and it's actually the most abundant monoterpene found in cannabis. So we thought it was a good candidate to maybe start looking at the effects of this terpene. So first of all, inflammation. This is going back to our intravital microscopy, looking at the rolling leukocytes, adhering leukocytes, and this time we also looked at just general sort of blood flow. And by locally applying beta-myrcene to an inflamed joint, we were able to reduce all of these components, indicating that beta-myrcene has anti-inflammatory properties. What about pain? So we did our pain behavior experiments. Here's a time course. The white squares are is the vehicle, and then we've got increasing doses of beta-myrcene. So there is a dose-dependent effect of beta-myrcene reducing pain. And then, of course, like all good pharmacologists, we wanted to see which receptors are involved, and what we've discovered here is by giving a selective CB1 antagonist called AM281 or a selective CB2 antagonist, AM630, we were able to block the analgesic effects of myrcene. So myrcene seems to be acting through cannabinoid receptors present within the joint. What about its effect on motor control? So we take videos of the animals moving around, and we can look at things like quadrant crosses, so just how many times it'll move into one of these different quadrants, so an indication of activity. The rats are very, very inquisitive, so they like rearing up and sniffing around. So we measure things like the number of rears and the time that they're rearing. To, again, looking at differences in motor control. And with each of these different paradigms, as shown, this is over 21 days. We measured them every single day for 21 days. The vehicle is in white, and then the beta-myrcene's in red. You can see with each of these different parameters, we didn't see any significant effect of beta-myrcene on motor activity. So the animals aren't having any sort of somnolescence, etc. So I just want to finish by talking about entourage effects. So as I mentioned, you know, cannabis, extremely complicated plant. We all in our labs look at individual little cannabinoids, which is great. But, you know, when you've got a complicated plant and people are ingesting cannabis in toto, what are the actions of those different compounds with each other? And this is something that's referred to as the entourage effect. Some of these have been found to be synergistic. The effects could be additive, or sometimes they cancel each other out and have inhibitory effects. So we wanted to see whether we could see any effects with CBD and beta-myrcene, whether there was indeed any entourage effect. So in these experiments, we give a low dose of beta-myrcene. We also gave a subclinical dose of CBD. So these doses have very minimal effects in our animal models to see if they cancel each other out or have additive effects, etc. We did our intravital microscopy for joint inflammation. We did von Freiherr algiometry for pain behavior. And of course, we did this in a model of rheumatoid arthritis in these experiments. Okay, so let me talk you through these graphs. So this is our rolling leukocytes and adherent leukocytes on the bottom here. So this is the inflammation experiments. So myrcene, compared to control, it was having some anti-inflammatory effects, but not with the adhesion of the leukocytes, because again, we wanted to use a dose that was having very minimal effects. These were complicated experiments, I have to tell you, because we had to do two different vehicles. So there's one vehicle for the beta-myrcene, which is soybean oil, and then we had to do a different vehicle control for the CBD, and that is this DMSO chromophore. So that's why these look so jumbled and complicated, I'm afraid. But anyway, I'm all about doing the right controls, so I'm a bit of a stickler for that. So anyway, what we're finding in the green is really the important part, is that when we give the combination of myrcene and CBD in these lower doses, they don't actually do any additive effect or any synergistic effect. So similarly with the pain, once again, so just comparing to all the controls here, myrcene at this dose does give a little bit of pain relief, but when we bring on board the CBD at a low dose, it wasn't really significantly different. So again, we're not seeing any entourage effect in these experiments with beta-myrcene and CBD. So just to summarize, what I've shown today is that we have a complicated endocannabinoid system residing and living in our joints, and I think it's a great opportunity and target to try and reduce pain and forego some of those centrally mediated side effects in the brain. Both cannabidiol and beta-myrcene are analgesic, they're anti-inflammatory. We didn't look at beta-myrcene with respect to neuroprotection, but cannabidiol is neuroprotective. Cannabidiol does, as we know, have a sedative effect. However, beta-myrcene does not have a sedative effect. And in these experiments, we were unable to see any sort of entourage responses. So with that, I just want to acknowledge the people who actually do all the work. So Nicholas and Melissa, they do all that complicated electrophysiology. Holly and Megan and Eugene and Alison all do the pain behavior and the histology, etc. I want to acknowledge the people who are funders, and particularly really want to acknowledge the Arthritis Society. They took a very bold step in supporting this work by, you know, they were worried that they were going to lose donors, you know, that people were going to be anti-Arthritis Society because they're giving money into doing cannabis research. Actually, the opposite was the case. They got more donors. People were interested. People were filling the rooms wanting to know more about cannabis. So I really take my hat off to the Arthritis Society for believing in us, and hopefully we've paid them back by giving some interesting results. Thank you.
Thank you, Dr. McDougall.